Hello everyone, my name is Sara, and today Bianca, Paul, and I will be sharing with you what we've learned about fetal intra-abdominal umbilical vein varix, or FIUVV for short. I will start by quickly covering some basic background information, and then we will talk about the role of sonography, associated abnormalities, prognosis, and management of this condition. Feel free to take note of any questions that pop up while we're talking, and we will try our best to answer them at the end of the presentation. Before we get into the details, I'm going to start us off with a bit of background information. The umbilical cord contains 3 vessels, 2 arteries and a vein. The umbilical vein carries oxygenated blood to the fetus, and the arteries carry deoxygenated blood from the fetus to the placenta. Since there's only one umbilical vein, it can be potentially fatal to the fetus if there's a disruption to flow. When the umbilical cord joins the fetus, the umbilical vein travels from the cord insertion to the fetal portal vein. This portion of the vein is the intra-abdominal portion and is the portion that we are interested in. Fetal intra-umbilical vein varix is defined as the focal dilation of the intra-abdominal umbilical vein. The vein is considered dilated when the diameter measures either greater than 9 millimeters or at least 50% more than the extra-abdominal portion. This condition is pretty rare. It affects approximately 0.1% of pregnancies according to the literature.
Hi everyone, my name is Bianca. So I will talk a little bit about the role of sonography in FIUVV. Ultrasound plays an important role in the diagnosis of FIUVV. As Sara said, FIUVV is the focal dilatation of the umbilical vein. It can occur extra-abdominally, but is most likely seen intra-abdominally. In ultrasound, it appears as an anechoic, round structure that is continuous with the vein. Usually the dilatation is seen between the fetal liver and fetal abdominal wall. FIUVV is defined in the literature as the extrahepatic portion of the umbilical vein measuring greater than or equal to 9 millimeters from inner to inner in the axial cord insertion plane, or when the diameter is greater than or equal to 50% compared to the intrahepatic diameter. The differential diagnoses include choedochal cysts, urachal cysts, distended gallbladder, stomach and ovarian cysts, and more. Therefore, it is important to assess any cystic lesion with color or power Doppler to rule out any differentials. Color or power Doppler can confirm vascularity. PW Doppler can also be used to help confirm venous flow. Thrombus formation can occur within the varix. It has been shown in the literature that turbulent flow and significant dilatation can increase the risk of thrombus formation. A yin-yang sign seen with color Doppler is indicative of turbulent flow. If thrombus is present, a hyperechoic area is seen within the lumen in B-mode imaging, and there is incomplete filling of the lumen with color Doppler.
Associated abnormalities documented in the literature include chromosomal, urogenital, and cardiac. These abnormalities tend to be present in 1/3 of FIUVV cases and are accompanied by a positive soft marker. One meta-analysis found 6% of fetuses diagnosed with FIUVV also had chromosomal abnormalities, most commonly trisomy 21. A different study found urogenital abnormalities to be the most common associated abnormality with FIUVV, and they also documented cases of cardiac abnormalities. On the right is an example of fetal pyelectasis. Early literature suggests a link between intrauterine fetal demise and fetal intra-abdominal umbilical vein varix, but more recent studies suggest prognosis depends more on the presence of associated abnormalities. There is a possibility that in cases of FIUVV with associated abnormality, that if there is an intrauterine fetal demise, then the demise may be due to the other abnormality rather than the varix. A possible lethal complication of varix can be thrombus formation, then embolization. This can lead to venous flow obstruction, and fetal hydrops may occur. Management of FIUVV includes timing of delivery and monitoring during pregnancy. Studies suggest isolated FIUVV diagnosis can lead to safe delivery with no preterm labor induction. and other studies suggest considering early delivery at 34 weeks gestational age. Methods of monitoring include genetic testing, the detail ultrasound, and growth ultrasound. On the right, I put two images to highlight the importance of monitoring. The top right was a detail exam at 19 weeks showing echogenic bowel. The bottom right shows the growth ultrasound at 35 weeks. There appears to be an FIUVV with intraluminal thrombus, which highlights the importance of having the extra monitoring present for cases of FIUVV.
In conclusion, FIUVV is when the extrahepatic portion of the umbilical vein measures greater than or equal to 9 millimeters, or when it measures 50% larger than the intrahepatic portion. It is important to assess this area carefully in B mode and color Doppler to look for any thrombus formation. During our literature research, we found that there is a low risk of adverse outcomes with isolated FIUVV. However, there is an increased risk when other structural abnormalities were present. Abnormalities include chromosomal, urogenital, and cardiac abnormalities. In terms of management, close monitoring and follow-up scans are recommended. The next two slides just shows our references that we use for the presentation. And thank you so much for listening to our presentation. Does anyone have any questions?